Sarah Johnson from my home state of Louisiana was just a few years younger than my grandmother. At the age of 86, she had committed her life to caring for others as a mother, as a grandmother, and as a nurse. According to her family, at the time that Mrs. Johnson contracted COVID-19, she was independent and feisty, still able to balance her checkbook and recite scripture. Her age certainly put her at higher risk of dying from COVID-19. Her being Black all but guaranteed it. You see, when Mrs. Johnson was admitted to the hospital, which was overwhelmed with patients at the peak of the pandemic, an encounter with a doctor deemed Mrs. Johnson's life unworthy of being saved, as was the case allegedly for other Black patients at this healthcare system now under investigation. Based on Mrs. Johnson's medical records, this physician pretty much wrote Mrs. Johnson off as non-viable when she pushed for her to have DNR status, do not resuscitate. She documented in Mrs. Johnson's chart that she was of advanced age, that she had severe malnutrition, renal failure, and advanced dementia. Except she didn't. Because also in her medical records, as noted by other healthcare professionals, she was only mildly malnourished, but significantly dehydrated. And her altered mental status was not that different than other patients with COVID-19 who presented with similar symptoms. And instead of the hospital calling the family to inquire about her functional capacity, her nutritional status, her mental status, they informed the family that there was nothing that the hospital could do to save their matriarch. And so the family reluctantly agreed to hospice, and Mrs. Johnson was discharged home. A later investigation revealed that not only had Mrs. Johnson improved prior to discharge, she no longer had renal failure. Her labs did reveal that she had an elevated blood sodium level, likely due to ongoing dehydration, where something as simple as IV fluids and close monitoring would have saved her life, as she was only mildly symptomatic with COVID-19. Instead, she was sent home to die, and her family was put at risk for COVID infection and death in having to take care of her. When I read this story, I was both infuriated and heartbroken as it hit really close to home. And it left me with questions like, what if she was younger? Would she have survived? What if she had been in a different hospital, a different city, a different state? What if she was white? This incident isn't specific to COVID-19, and it certainly isn't an uncommon occurrence, as I've had something similar happen with my grandmother. Just a few years ago, while I was seeing patients, I got a frantic call from my aunt, who had taken my grandmother to the hospital because of delirium and difficulty breathing. She'd only been admitted for a couple of hours when an attending physician wanted to talk about her DNR status and her end-of-life plan. He hadn't even figured out what her diagnosis was, but he wanted to talk to us about her dying. So I had to leave my patients in the lurch. I dropped $1,000 on a flight from Maryland to Louisiana to advocate for my grandmother. The outcome was a diagnosis of pneumonia for her, and thankfully I still have her in my life. But it was also an opportunity to school this physician on bias in medicine and inequities in healthcare. Unfortunately, unlike my grandmother, Mrs. Johnson didn't have someone at her bedside to fight for her, as is likely the case for numerous Black and brown people across the country, as the age-adjusted COVID-19 death rates for Blacks is over 3.5 times that for whites. And in the Native American and Latinx community, it's at least 2.5 times higher. Now, let's be clear. Before March, conversations about race-based differences in health outcomes were limited to public health lectures and academic settings. Then came COVID. When 30% of a state's population makes up almost 80% of the deaths related to COVID, clearly this pandemic has revealed the ugliness within this country that has existed since its inception. Simultaneously, we bared witness to the murders of Ahmaud Arbery, Breonna Taylor, and George Floyd, hearing yet again those gut-wrenching words, "I can't breathe." As we witnessed Mr. Floyd call out for his mother, as a person paid to protect us, ended his life with a knee to Mr. Floyd's neck. People like myself have invested our entire careers into dismantling the systems that facilitate disparate morbidity and mortality revealed by this pandemic. We understand that these health disparities were rooted in health inequities that existed well before COVID showed up. We also understand that this isn't simply about disproportionate burden of diseases like diabetes, heart disease, and obesity, but about social norms and legislated racism that influence the social determinants of health. Those factors where we are born, grow, learn, live, work, play, pray, and age that define 80% of our health outcomes, and either provide access to resources like healthy food and safe space for physical activity, or facilitate the devaluation of Black life. Society, the medical community included, would have us all believe that disease risk, police assault, and early death are all due to individual behaviors, especially within communities of color. If we act right, if we eat right, then we'll be all right. As if the inevitability of diet-related diseases and dying on the streets is simply based on personal choice and not the systems in which those choices are made. When I think back through what's an excellent example of this, I think back to slavery, and I think about my ancestors being stolen from places like Sierra Leone and having to travel through the Middle Passage, and the impact that that had on their hypothalamic pituitary adrenal axes, and how those effects have transferred from generation to generation to generation. If the Dutch potato famine of 1944 in Europe can facilitate increased risk of obesity and heart disease among adults born to women who were pregnant at that time, imagine the transgenerational impact of the combination of slavery, Jim Crow, segregation, and modern-day racism on the health of the Black community. And then you combine that with policy-driven, purposeful design of communities that minimize access to healthy food, safe space for physical activity, and affordable housing, and instead maximize the deluge of fast food establishments, liquor stores, and dialysis centers. This isn't about individual behavior or personal choice, but about systematic discrimination and systemic racism with roots that run deep from the federal government to corporate America. And it isn't simply about access to doctors like myself, when we know that policies passed have implications on health in all ways, from creating disparities to facilitating equity. We can look at housing as a perfect example. The Federal Housing Administration is notorious for having historical institutional racial preferences that allow whites to have access to capital and purchasing land while simultaneously blocking out that opportunity for African Americans. And it isn't just at a federal level. We see it locally in states and cities like the District of Columbia, where race-based policies and exclusionary zoning practices have facilitated the concentrated wealth within white communities while shrinking it in Black, so much so that the segregation created by these policies can still be seen now. Imagine the multi-generational wealth loss based on this institutional racism and how that has impacted health. But I'll tell you, you don't have to imagine it because it's still happening now. It's called gentrification. When developers partner with governments to infuse resources and cash to revitalize neighborhoods, that results in a demographic shift and a push of communities of color into concentrated areas of poverty with inadequate resources, subpar schools, and a fractured health infrastructure. This isn't just limited to federal and local policies. If they're legislating health disparities, corporate America is orchestrating them. And there's no better example than the beverage industry. They've pledged their allegiance to supporting the Black Lives Matter movement, but their money speaks a different tale. They, over the past 5 years, have infused over $1 billion in advertising of sugary drinks, with a disproportionate amount of that funding targeting Black and brown youth to increase consumption, while simultaneously vehemently opposing any legislative action used to curtail consumption of these sugary drinks that are killing us, all while simultaneously making record-breaking profits. And what's the result? Black and brown children seeing at least twice as many advertisements for sugary drinks that then facilitates increased consumption and heightened risk for chronic diseases like diabetes, hypertension, and obesity. But for all the challenges within community of color in terms of health disparities and health inequities, all is not lost. When we join our forces together like superheroes Communities come together. That's how change happens. When they came for our music, we fought back and we won. When they came for our campus, we fought back and we won. When they came for our civil rights, we fought back and we won. We're putting everybody on notice because now's the time to fight for our health. Our voices will not be muted, and neither will our health. We will join together and we will shut big food and big soda down from targeting our communities and bringing poison to our children. We will call on our elected officials to create norms, practices, and policies to dismantle the institutionalized racism that facilitates these health inequities. That's how change happens. It's the foundation upon which I have built my career as a physician, as a public health expert, as a mother, and as a Black woman. I use my position as a clinician to not only help my patients in their health issues, but to address the social determinants that drive those health issues. I use my position as a professor at the Milken Institute School of Public Health at the George Washington University to raise up the next generation of culturally competent, community-engaged public health professionals. I use my expertise as a public health professional to not only help craft legislation to decrease things like sugary drink consumption, but I also call on big soda and big food to stop their deceptive practices in influencing our national and global food policies. As a community member, I advocate to make sure that Black lives do matter. And I write testimony and give oral testimony to my elected officials to make sure that they legislate in a way that allows each of us to reach our full health potential. And when they don't, I use my pen to vote. This journey, although rewarding, can be quite challenging. But in the amazing words of the late, great, incomparable Congressman John Lewis, if not us, then who? If not now, then when?